applied or are applying formative assessment results?
Okay, thank you very much. In Ghana, the situation is very similar to what Janet mentioned about Malawi. There is a gap in knowledge. Ghanaian women are very eager to do what is best for their children, whereas in other countries, women are shy about breastfeeding. In Ghana, women are not shy. They will take out their breast openly in public to breastfeed, no problem. And so we are happy about the exclusive breastfeeding rate. It's climbing. It's now at 63%. But the challenge begins when complementary food is supposed to start at 6 months. Some women are not able to do exclusive breastfeeding up to 6 months. It's because they think the breastfeeding or the breast milk alone is not enough, and so they will start around 4 months to include other foods. We have the second group who at 6 months do not know what to give. Should I give watery porridge? What should go into the food? How many times should I feed it? Should I give a bowl full? Should I give just spoons? And so this is what our literature review found out. And that is what the Ghana project is seeking to address with our implementation. Thank you.
All of you have found opportunities to integrate nutrition into other community-based sectors. How have you engaged partners outside of nutrition?
As I told you, what we tried was to integrate nutrition into agriculture through urban garden project. And what we did was we trained the agriculture extension workers and the community mobilizers who are under that project. That's how it started. And in one of the trainings, one of the agriculture extension worker was telling me that I give a soul to his project because he's producing and he don't know how to use it and how to give his products to the unseen beneficiaries behind his OVCs and caretakers and adult HIV positive beneficiaries. Behind were children under 2, under 5, who are not seen by this project. So that's what we did.
Belaynesh, maybe you can talk a little bit about some of the challenges you found in working in sectors outside of nutrition, trying to integrate nutrition with them.
Yes.
How did you overcome those?
Yeah, through different discussions, we ended up in convincing them that production is not nutrition. So after, they were resisting because they are agriculture people, they have their own products, and our assessment showed that they are not using that product. So that was how they were convinced. And mothers were telling us that after providing with some doable messages, they were telling us that they were starving their children by giving gruels, a very thin gruel, water, nothing else. And after IYCN has provided with all these informations, and we have also prepared counseling cards, which is a very comprehensive one. That's how we integrate into agriculture. There are messages here, they have the production, but these two were not together. So we bring the production and the use to make a nutritious food.
Mireille, in Haiti, you also developed counseling cards. Maybe you can tell us a little bit about that process.
Thank you, Altrena. I should say that one first work that IYCN did was to put together partners in nutrition. And this was a must because in Haiti, the opinion regarding breastfeeding wasn't shared by everybody, especially in the context of HIV. We had two mainstream, those who were for in favor for exclusive breastfeeding, and those we were against it. So the result was that in the communities, the mothers were doing whatever they wanted, and they were mixed feeding, which is very bad. So our first work was to, with the Ministry of Health, put together all partners for brainstorming, and we invited experts from WHO Geneva, from Zimbabwe. We had Peter Ilef, and we had a 3 days workshop. After those days, all the partners with the Ministry of Health came to a consensus, and they had a choice, and IYCN helped the Ministry of Health develop the norms. And from those norms, we elaborated 2 specific trainings, which were one on optimal infant feeding, which were addressing exclusive breastfeeding because it is a real need, and also transition through well-equilibrated complementary feeding. And we began with the trainings with those 2 tools, and all during this time we discovered that the need to also make posters and flyers. And finally, the counseling card we are proud to show, which is a hard work from all the team, especially Nicole, which is sitting in front of me. And those tools are really, thank you, helpful in breastfeeding, because the health workers we are training can then use them to have a uniformed and standardized messages, so that we no longer have, people with a lot of willing but giving messages that can be contradictory. We actually have same key messages that people from different views and different institutions can together give to the community. And what I'm very happy to talk about is, in the pictures, they are real person, and they show messages that sometimes go against the habits. For example, here you see a man cutting food for his wife. It is not everywhere like that, but it's like a suggestion. Well, you could do that also. So it is not the main message, but after working with the health workers, the men discovered we could do that. Why not?
Thank you. I was going to ask you about those subliminal messages that are in some of the cards, and in some of our other programs too. They've tried to promote men in the counseling cards, promote male involvement as well. Maybe Faith, you can tell us a little bit about male involvement. Okay.
Thank you. The work on working with men began with the pilot training of group leaders who are working with, basically who are men who are HIV positive, and they have group leaders who are trained. And the work with men began from there, in that they developed some work plans, and they went back, and each of them leads groups of between 15, 20 other men. And so it was about mainstreaming messages and information on infant feeding into what they do routinely when they meet to discuss issues around HIV. This was done in partnership with PATH in one of the regions in Kenya. And so men are being 2 ways. They are being role models. We have one just behind me here, poster here, and some of our materials show what some of the men are doing as an example. And so it's about passing messages and being role models at community level, saying and showing that men as a part of the family too can support infant feeding. It was a big issue around gender also. So during the training, the whole issue around gender and the roles of men versus women was discussed. And men began to embrace the fact that they too can play a role complementary to what the moms do. And so we have had increased situations where men will accompany their wives to the clinic, and we have issues there because most of our facilities and the services are not male-friendly. But it's speaking on a little bit because the socialization of a man is that that's the work of a woman. So the big issue is to put across through a process of dialogue that men too, within their cultural roles of providing for the family, can support feeding practices for young children and their wives, especially when they are nursing or pregnant. And I think it's taken off well, has a lot of promise in terms of helping us increase uptake of the proper practices. The situation was that women would come home with a message from a health facility, but a man doesn't have that information, a grandmother doesn't. And so being able to do what health workers are telling a mom is that much more difficult when she's operating in a context where those around her who are very central in making decisions don't have the same information, don't believe what she's being asked to do. So pulling in men has been very central in helping us move forward, and we hope in days to come we can be able to see improvement in indicators of better feeding practice for young children.